it's just a way in which, so this was basically part of HESC 430, which is my class over at the college for instructional presentation, right? And so in this kind of class project final, project, it was something that, okay, how can I combine what I need to do over there with some things that we need to do hands-on here? And not so much with the day shift, I'm thinking, but I know the night shift, we've had a few issues with epiprostinol and bronchoscopy. Not anything, procedural-wise, it's mostly just getting the equipment together and getting it started. That seems to be the biggest barrier. And especially when it comes to epiprostinol, come on in, get some food. Especially when it comes to like epiprostinol, it seems like it's a process to get the equipment up, get the drug ordered, and get it running, right? Once we got that, we can kind of like take a chill and figure out the next steps. But
thank you.
It kind of is the initial kind of setup. And I say this is use the resources in which you have around you. The nurses, right, are all about this pump. That's what they do. They can do it in their sleep. And a lot of times I'll be like, hey, Nurse Jackie, can you come and help me, thread this pump? And they're like, do-do-do-do-do. And you're like, whoa, 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 okay. Again, slow down a little bit and kind of see and teach me a little something.
Step by step.
Again, they're there, right? So use them. And the same thing goes for once I do start the epiprostinol, we want to watch for the blood pressure, right? So I use those people to say, hey, Huck, hey, nurse, I'm starting this drug. It has a tendency to really knock out your blood pressure. Let me know, right? And so use the resources in which we have. Sometimes we therapists will be like, well, I can't do anything for 30 minutes. I'm sitting here watching the patient, right? And it's like, well, technically that's what the policy says, is to monitor the patient for 30 minutes, but your interpretation of monitoring may be different than my interpretation of monitoring, and we have to use the resources which we all have, which is other people. So, yeah, right. So, well, it's happened before, but anyway, so this is epiprostinol initiation, monitor, and weaning. At the end of the session, we will be able to summarize the 5 classification groups of pulmonary hypertension. We'll be able to explain and demonstrate the initiation and demonstration and weaning of epiprostinol. So not to get too into the weeds of this, because as I was kind of putting this together, I started reading about pulmonary hypertension, what it is, and what goes into it, and it's like, and then you just start getting into something like, whoa, this is more than what I was wanting to do, and so I kind of had to back up a little bit and take it from a perspective of, it's 2 o'clock in the morning, I need to start epiprostinol, how do I get this done? Safely and efficiently, right? So that's kind of what I came back to. But I wanted to at least include a definition of what pulmonary hypertension was. And by definition, it's a pulmonary arterial pressure greater than or equal to 25 millimeters of mercury at rest, measured during a right heart cath or a Swan-Ganz or something like that. So typically, it's not something that maybe Gabby remembers when we had Swan-Ganz catheters around, but that's far and few between anymore, right? And so this brings in kind of the next slide, is this whole thing on pulmonary hypertension is, what is it? Well, the more I got into it, it is well, first, it hasn't been studied that much, maybe in the last 15 or 20 years, not like heart disease or something like that. So it's really kind of this general, vague symptomology that's incorporated into a lot of different disease processes. So back in 2013, they met and had a congress and kind of put together 5 classifications of kind of where these people fall into. They're all having pulmonary hypertension, but from different causes, right? And so that's the kind of the difference here. We're more interested in group 1 side of things. So if you remember from A&P many years ago, that there's two kinds of circulatory kind of blood distribution. You can talk in here. You don't have to go out there.
Respiratory scoring.
So we have the lungs. So that's the pulmonary circulation, and then we have capillaries, right? Which is
You can stay. I'll be right back.
systemic circulation. So we're not concerned with the systemic circulation right now. What we're concerned about is this pulmonary circulation. So, and in particular, this right here, going from the right heart to the lungs. This is what epoprostenol has an effect on right here. So epoprostenol is the drug that we use here, and it's a prostaglandin, which is a hormone-like substance that occurs naturally in the body. It regulates things, a lot of different things, but in particular blood pressure and muscle contraction, and it specifically can vasodilate that pulmonary vasculature very quickly. So of the maybe 7 times I've ever started this, in 3 of those it was definitively, oh, you dropped your pressure. And it's one of those things where it's, you know, per protocol, which on your handout there's some guidelines of going through what you're kind of looking for. Once you do start it, you're looking for a decrease greater than equal to 10%. It's not a situation that I've come clinically as to, well, let's see, the blood pressure was 120/80, but now it's, you know, 90 over whatever. Is that 10? Is that? No, it's like, oh my gosh, this is, it dropped. And you're going to see it in about, I've seen it in the first 10 minutes. So that's the biggest thing when we're starting out, is to look out for those types of things. A lot of people get caught in the weeds of, once I get it started, what am I supposed to do? I don't know. Should I get a blood gas? Or I don't get a blood gas. What's this PF ratio, G-JAW? I'm not sure. I don't know. Oh my gosh. So I will say that when you put the order in EPIC, whether you type in refractory hypoxemia or you put in epoprostenol, EPO, whatever you put in that order set or that order box, it's going to pop up with epoprostenol. And this is the order set that comes up. So this is your standing orders, and really it'll tell you right here, vital signs every 30 minutes, monitor mean arterial pressure every 30 minutes. Baseline PF ratio, so you're going to have to get a blood gas initially before starting this. Get your ideal body weight. And then it tells you what kind of check to do, Q4. And so a lot of that stuff is right there, right when we put the order in, if we don't really know what to do. I printed off and made a pocket guide in one of those, which is kind of some quick tip points of what to look for when you are starting epoprostenol. That, and as well as we have a step-by-step instruction in every ICU of how not only the first 3 or 4 pages is steps in which to look out for and kind of what we're doing blood gas wise, but more importantly, step by step with pictures of how to set up and push every button to set up this pump. It's in every ICU. Okay. I highly suggest when we are using it that we grab it and, you know, maybe hang it while in use, because it is quite useful.
And they just do that in ICU, right?
Correct. Absolutely. And this is the thing too, is I know a lot of people are like, well, where's our pump? Where's our stand? Because we had an epoprostenol stand. Know that you can get any pump anywhere and put this on. The only reason that we had our own kind of initially is because it was programmed differently, but with these new pumps, they're all programmed universal.
And the nurses have to do that part.
No, we do.
Oh, we do.
Well, we can do it, but we can ask for help if we need their assistance. Absolutely.
Okay.
And I say again, use what you have. Use those people to your advantage. So real quick, again, what are we doing? Let's just think through what it is we're doing. Okay, we got to start it, but before that, we have to get a baseline, right? So we need to get a blood gas prior to any of this happening. So you get a blood gas, you get your PF ratio.
Right before you do it, or can it be
Correct.
after?
Well, it has to be.
Before?
You want it to be within an hour or two, right? Because you want a fresh PF ratio. So the idea is you're going to start your epoprostenol. You're going to look out for that drop in pressure, all right? And then the protocol will tell you to wean it to find the greatest effective dose. So let's just walk through that for a second. So what that means is, so we're going to start out, it's weight-based. So I can tell you with an adult, it's going to max out at 15 nanograms per kilo per minute of drug. You start it, I don't have any drop in my pressure. Then per protocol, after 2 hours, you draw another ABG and you get another PF ratio. And you see if the PF ratio has gotten better, right? If it's gotten better, that means you have a positive response, okay, to the drug. The idea then is decreasing that by 10 nanograms per kilo every 2 hours until the PF ratio drops. And then you know, well, that last point you were at is where you want to be. I would say clinically, so let's think that through. That's why I don't really agree with some of that, because in clinically what I've found is once you start it, the attendant is going to go, keep it. Because at this point, your patient's probably been, this is sometimes a Hail Mary let's just do this, right?
Yeah.
So typically I'm not finding that's what they do, it's what they want to do. I have printed off the protocol and said, this is here, and they're like, no, I don't care, leave it.
Right.
All right? So that being said, I will say I would probably be more comfortable with doing that for 24 hours, right, or maybe overnight, and then in the morning, where are we at? What's we going to do? You know what I'm saying? Because you got to think why we're using this. The reason that we're using it is probably because, again, we're on our last kind of legs anyway. So are we really going to stretch that thin, right? You got to have some wiggle room. So I've found that clinically they'll say start it and leave it. All right. However, then so the idea would be you're getting your PF ratios, you're getting those blood gases. So it is nice to have an art line.
So are you still, even though they want to hold it for like a period of like a day, they put it on, they kind of want to not have you do stuff?
Correct.
Are we still supposed, I know we do checks, that's correct, but are we still doing gases and checks?
So this
for
is it.
Others, like,
this is the thing too, is once you start epoprostenol, if you are going to decide if it's the epoprostenol that's getting better or not, I would hope that you didn't make a mechanical vent change. Because you can't do one or the, you got to do one or the other, you can't do them both, right? So what you do is you max out, the idea is you would max out your vent settings anyways first, all right, and then start this. So if you are going to titrate that to find the greatest effective dose, you can't be making any vent changes while you're doing that.
gotcha.
All right. So this is what's different between what's per protocol and what you're going to see clinically. Okay. So I will say what you're going to see clinically is you get it going, get it started, and then maybe that next morning in rounds you start putting forth those questions in rounds of do you want to keep it at 50? Should I start weaning it and see what my PF ratio is going to start doing, right? So if that would be the case, then you would be taking it down by 10 nanograms per kilo every 2 hours or so, right? At which time, after the 2 hours, you get a gas and you see what your PF ratio is, right? So the idea is to kind of be in a situation where you're monitoring that with maybe what else clinically would we see? Saturation, right? And so this is getting back to the previous slide of the 5 categories. This is kind of why we find that we're starting this and maybe it's really not indicated. Because really, quite frankly, when it comes to pulmonary hypertension, there's a lot of times you don't know what's causing it. And as such, sometimes it's like, well, let's just put it on. I'm not saying that's right or wrong, I'm just saying clinically, that's what we may find, right? So in the initiation, this is what you're going to look at in EPI. You're going to, and the biggest thing that people want is this initiation completed. That's where you're giving your productivity, and this is a billable procedure, so you do have those standby times available to you.
Does initiation completed mean you started it and set it up, or?
It means that you started it and it's running.
Oh, running, okay.
Yep,
Complete.
and then monitoring comes in here. This is your charting for monitoring. So it's going to ask, again, did you get an ABG after 2 hours? What's the PaO2? Then what was the PF ratio? What was the MAP during all of this? Did it drop? And the time spent doing that. I think the pick list, Gabby, correct me if I'm wrong, is in 15-minute increments. Like, but at any rate.
The question is, how long, because the last time we had to put 2 epiprostinils on at the same time, on night shift, and it seemed like it took 20 years for pharmacy
Very good
to
point.
send the stuff.
So this is what I do. I get the order in Epic, get the patient's E-number, call pharmacy and say, this is Gabby from CCU, Mrs. Bears in 2513, E-number 1111111, has epiprostinil ordered, I need it as soon as possible. And they're typically like, okay, I will, what's your contact number? So you can give me either your Vocera or the unit number. Tell the HUC I'm expecting a call from pharmacy, and that gets the ball rolling, right? Otherwise, it goes in queue behind everything else down there. Let me know if that's not happening. Travis is always asking me, any issues with epiprostinil? Any issues with epiprostinil? Because they've been involved with some lag time before, and if Travis knows, he can put the fire under some folks really quick.
Okay, because I remember it taking
If it's
a
taking
really long
more than
time.
20 minutes to get that bag up, we need to know about it. So that brings another good question, is how do they get it to you? Well, sometimes they will call and give me a code for the tube station, right? Which the tube station sends it to the unit, and the tube station is locked until you put your code in. So they cannot just
I
know.
didn't know they could do that.
Yeah, just know that they can't get any other tubes until you go and type in your 4-digit code that they gave you.
Oh,
So that's called a secure send.
didn't know that.
Other times I went down, I'm sorry?
Do they call you to let you know that they?
Yeah.
They'll call you and say, it's ready, here's your code. Or it's ready, how do you want it? You can either come and get it, or you can send it up to me secure too. I always say secure too, because what am I going to?
Why would I leave the ICU to go pick it up?
I've heard some situations which the pharmacist didn't know or said, no, you have to come down and get it. And I just think it was somebody that didn't know about the tube, but every time I've ever had it, they've sent it to me, secure tube.
Well, now that I know, I can just be like, no, secure tube, please.
Secure tube.
What's the code?
Yeah.
They
Just
And it's usually like 1976, or it's like a you know.
70 years.
And so so that's the hardest thing. It's getting it up from pharmacy, getting it on the patient, and getting it running, right? So that's the first stages of any of this. Then I've got some time. Okay, I'm going to be in the room anyways, for at least I would think 10 or 15 minutes, seeing what's going on, right? So I've got some time here to figure out, okay, what's my next steps, right? So again, use those things, use that time that you have. At least it's up and running.
Right.
At least it's running. I mean, that's huge. At least it's up and running. Because we've had issues where I don't know, I didn't know how to do it, and it delayed the actual initiation. We have to get it. We have to get going on it. And then I don't want to spend too much time titrating it, but that's the idea. Is you are going down by 10 nanos per kilo of ideal body weight every 2 hours, and once you get to what's the base? Once you get down to 10 and everything, and you're hemodynamically still stable, your stats are still good, then you get rid of it. All right. Marring is very important. If any of this, and I don't have a snapshot of it, I realized last minute, but marring is really the key to all of this. When you look at the MAR, it'll say, are we all familiar with rate dose verify on this drug? You know how we pick when you more albuterol, it'll say given, right? Well, you can pick from that list and say rate dose verify for something like this. So you just go into MAR, wand the bag, and say, okay,
It's
it's
broken.
running currently at 50 nanograms per kilo. Boom, right?
It's broken.
Maybe 3 hours later, for your next check, you come in, I do the same thing. Race dose, maybe now I'm on,
So, you know, something I
you know,
tried to
so on
So
50.
you mean you're scanning that and scanning that?
So you scan this, you know how you scan the patient?
Uh-huh.
And you scan your med?
Okay,
Same way,
okay.
all right? It's the same
I've not
procedure.
done that, so I don't know.
So the thing is once you're going looking at your MAR, you can say, okay, I came in at 7 o'clock, at 7:10, I was at 50. I weaned it at 11:10 to 40, and then I was at 40, and then it was at 40, and then at 2 o'clock I hung a new bag, because I'm going to now wand it and put, instead of rate dose verify, I'm going to say new bag, right?
Do you have to call for the new bag?
Yes, you would call for the new bag. And that's why we should get real quick on setting this up, and you'll see, it'll tell you based on how much the patient weighs, how many cc's per hour it's going at, right? And then you just divide it into a bag of 50, and then it'll tell you approximately how long that bag will last. So when I hang it, I always say 45, just to make this beep a little sooner than that would be dry. And then I will say, okay, it should be enough to go, let's say it calculates out 7.5 hours. Well, I'm going to call at 5 hours. So I'll just make a note, call pharmacy at 5 hours, order a new bag,
Right,
right? And then have it up here.
okay.
So when it does, I've had nurses go, oh, John, I've spiked your other new bag. Okay, thanks, right? Because I'll have it hanging right here. When this alarms or it's almost out, then the new bag gets spiked. And then you change this to volume to be infused would be now 50. Yes. So again, the biggest thing is once you start it, okay, you don't stop it unless you,
As long as it makes the cardiac arrest.
yes, that's right. So that unless it's a situation which you have decreased your mean pressure, you got to keep it going. Okay. So that means if I am in a code situation, right, and I'm bagging a patient, you have to have it in line here. And what I suggest is when you're in that situation, somewhere during the day when you come in, I have this in the vent circuit, right? So what I do is I just get another Aerogen, have it in here, plug, and then all you got to do is take it out of the vent circuit, put it here, and you're not fumbling with all this tubing and pieces and parts, right? It's there, it's controlled, it's still going, you don't have to deal with this. Now you're just doing your CPR with your bag. And you're still...
Did you say what the reason this medicine's for? Why
So-
are we doing that?
So again, it's for pulmonary hypertension,
To reduce it?
to reduce it.
Okay.
Because what's happening is, the thinking is the reason that the sats are so low is because there's so much constriction going on.
It's to open it up.
So what it does is it's a vasodilator,
Okay,
right?
gotcha.
So with any vasodilator, it can tank your pressure, right?
Sure.
So that's the whole idea with doing
To open
this.
them up, but watch the pressure at the same time.
Yes, for at least the first 30 minutes. That's what's important.
Okay.
So why don't we, so the bag is spiked, right? I spiked my bag, I got it up from pharmacy, and now I'm going to prime my tubing. So what I do,
Do you have a special tubing that's for this, or you just?
so
use
good
yours?
question. It's, you go to the nurse and say, if you don't know where it's at, and say, I need a primary set of IV tubing. It's-
Primary.
They have primary and secondary. Don't ask me what primary and secondary means. First and second, okay, other than that, I think it's a piggyback. The secondary is a piggyback situation where
Like
it goes
off of something?
into here.
Okay.
right.
Yeah.
So, primary set of tubing. And it comes with this protection on here like that, right? So this is where it's going to go into your pump. So I spiked it, and I'm going to make sure that,
Spiking it means you zapped it.
Yep.
Or, okay.
Yep.
Zapped it, put it in.
and so
the
there's a
mouth.
clamp here, and the thing that you got to watch out for is you don't want to run this. If you spike it and make sure that, if you spiked it and didn't close this, everything would just whoosh.
Yeah.
You have to, and
then
it
you-
does quick.
Guess what? I need another bag.
So yes, yes. So you'll see it
Yeah, it's coming down.
you'll see it feed through, right? So it's not, so you can control it pretty well. It's not, but if you forget,
You're in trouble.
I remember once on night shift,
You do it
I
once,
spiked
you'll
it,
never forget.
and
Yes.
I spiked it, and it went, and I caught it right as it came out. I mean, just like,
Oh,
it was,
lucky.
You were good. Good reflexes, right?
that is a.
It's coming out at the end, John.
So you don't want to do that with epoprostenol, right? So what I do is, I'm
You don't want it
much,
to drip at the end?
no, I just get the first couple because I don't want to
Yes,
waste it,
right.
right? Because it is like,
It's
the
been-
bag's going to look like it's almost empty because it's just,
Yeah.
it's
But
just.
it's inhaled, so you have to think it's not like
Yes,
an IV.
so what's happening is you're just dripping a drop in here every
Yeah.
minute or so. So you're going to hook that up to your aerogen. Well, first you're going to put this in. So what happens, this little blue guy here, what I do is I start at the top, I drop it in like that. And then this guy goes in here, so blue, and you kind of got to pull it just a little bit to go in there.
Slide it in.
Okay, and then you're going to shut your door. So now you've loaded your pump, right? Power up. And now I can get rid of my
Lock.
lock. And where did my guy go?
Aerogen's in the back.
So let's talk really quick about what that looks like, what the aerogen looks like. What you want to make sure is that your aerogen on your vent circuit is running. Every check, every time. I can't tell you how many times it's stopped running. If it's not running, it's not doing any good. So you push and hold to put it to continuous. Right? So now I'm on continuous. It's got to be plugged in to run on continuous. So you got to make sure that every check you're coming in, every time I'm in the room, you want to make sure that's running. We've had issues with two controllers, one on the vent, one on the stand. Which controller was operating what? That's been an issue too. So just trace your lines out. Know what's going on in your room. Know what's going to where.
Do you put stickers on your lines?
Yes, so we do have stickers that say respiratory use only like that.
Okay, good.
And that comes up with conformity now that way.
Love it.
So we're going to say yes to new patient, all right? And then it's going to say, I'm going to say no to that because, so, because this is a little different if I didn't say that.
Hey John,
Yes,
how many cookies can I have?
all of them. So we're going to say yes for the new patient, and then we're going to say adult. Actually, no, we're not. Sorry. Guardrail drugs. Exit. Because see, what I did is, because I did this earlier and set up, and I told them I was respiratory, but I wanted to get back to if
When you
you,
first started, yeah, you have to.
because you have to tell it, answer, when it asks you if this is an adult patient, you have to answer no.
Wow.
Which is, again, this is, because what they did is they reprogrammed the pumps, and our epoprostenol system was changed a little bit. So this
So
is,
you have to say no if it says
so you
adult.
have to say no to an adult patient, which I hate that because it's so not intuitive, right?
Right.
So then what that does is bring up your epoprostenol
Because it's an infant.
because it's a, well, it can be, yes. So I'm thinking then if I go back on, I wanted it to look like it was if I was going to pick this straight up off the floor.
intubated and has to treat.
Yeah.
And she's not being ventilated right now, what are we
I
doing?
know.
No wonder she
New
looks like
patient.
that.
So select yes for new patient. Adult,
No.
no, which you're like, what? Because this is what screwed some people up before in the past, is
see
because
how.
it's like, "Well, I'm not finding epiprostinol, I'm not finding epiprostinol." So this is what we made a little modification here. We're gonna say no, all right, and then we're gonna hit respiratory. Confirm. And then enter patient ID and press confirm. I wonder if I can just hit confirm without that.
Is that where you scan them?
Yes, maybe, right. Confirm. When the channel select appears, go to infusion mode and press channel select. And then when infusion page, select guardrail drugs, epiprostinol. It's asking you 1,500 micrograms and 50 cc's was selected. Is this correct? Yes. So here we have patient weight. We're going to say we're 75 kilos. Enter.
Do you get the weight from their
And
chart?
yes. So up at the top, you'll hover to discover. So you put your cursor there, and it'll give you ideal body weight.
Oh.
All right. Next, volume to be infused. I'm going to say it's going to be 45. I always usually use 45. And we're going to say start. So now I'm running at 50 nanograms per kilo per minute. And to give me that dosage, it's going to run at 7.5 mLs per hour. So what I do is I divide 7.5 into 45 or whatever, and it's going to come out to like 6.7 or something like that. So it's going to be like, okay, so if I have like 6.5 hours before this runs dry, I'm going to make a note to tell pharmacy to send me another bag in 4.5 or something like that, just so you have it. Or it's nice to tell the next shift, if you're going off shift, hey, you're going to need to call pharmacy at 9 p.m. because you're going to need a new bag at an air in line because I didn't purge well enough. Because this bag is old that I'm using and it's throwing in little
Yeah, you want no
little
air in
blurbs.
there.
But so anyways, that's again, use what you have available to you. Use those people around you to say, hey, again, hey nurse, I'm starting this epiprostinol. Let's watch out for that pressure. So you're going to get your PF ratio, you're going to get some vitals, you're going to get your SAT, you're going to get your heart rate, you're going to see what your mean pressure was prior to starting. Because if I don't know where I was, I don't know where I'm going, right? So you kind of need to know your baselines, and that's it. That's literally it.
And if they suddenly get like all this crazy like volume or all this like, or if they have, aren't you looking to see if their pressure drops, their blood pressure?
So you're seeing to see, that would be a contraindication of this because you don't want to tank their pressure, all right? So you want to start it, you want to continue it, but you don't want a decrease in pressure
By more than
more than 10%,
10.
I believe is what it says.
It is 10.
So that's the true safety of this whole thing, is making sure that doesn't happen, all right? So then the idea after that is, say they were cool on the pressures, right? So then the idea is in 2 hours it would be nice to just draw another gas to see if that's improved. See if your PF ratio has improved. See if your saturations are improving.
So if your saturations stop improving, then you keep it there.
I
You don't
would,
titrate.
correct.
You only
So-
titrate if it's improving.
You only this is it too. This is where I kind of fall off this whole weaning
Oh, yeah.
thing. Is if you have a PF ratio starting out that's 100 per se, right? And I start up a epiprostinol, my pressure's fine, and I get a gas in 2 hours, and now my PF ratio goes to 110. All right? Well, that's not that much of a jump, right? So why am I going to wean? Because when I wean, I'm looking for a PF ratio drop greater than or equal to 20%. So if I only went up by 10% on my PF ratio, why start weaning to 40 and 30?
Right.
It doesn't make any sense, right? Now, it'd be different if I started it and my PF ratio went from 100 to 470,
yeah.
right? Which I don't think it ever would, but you never know, right? Then I'd be like, oh, okay, let's turn it down to 40 then,
So you
right?
always go by 10.
Yes. Always go by
Anytime
10.
and then you get another PF ratio, get another gas in 2 hours?
Yes, because this is it. If you're going to turn this down,
No.
you either one of two instances that's going to happen. One, you're going to try to find the highest or the lowest effective dose for the patient, or you're going to wean it per physician order because for whatever reason maybe they don't want it anymore or they're one-way wean or whatever.
You never
right?
just stop it though, but I've had physicians say.
You never stop it cold, absolutely.
But I've had physicians say they wanted it stopped cold. Stop.
Cause I think, isn't it like, how low can you get before you can? I
Can
thought
what?
can stop it.
10.
10, yeah, so if I guess you were at like.
You're at 10.
10.
Well, just know that, again, that is a communication between the physician and you.
And you just
So
try.
I say, you know what, if that, this is not the way we wean that, can I at least take it down by 10 every, 30 minutes or something to it's kind of, and if it's a situation, because I don't know what that situation looks like. Maybe you were going into a one-way wean situation and that's where we're going to go anyway.
No,
So,
usually no.
but I will say, if you can't, and if it's an attending that said that, or,
Oh,
well, again, that's one of those things where he is in control of that shift. So as such, then if that's,
Just make a doctor note.
yep, you make a note, and it is what it is, right?
so
But-
what if stuff does go crashing down and you do bag them and that's like, can you give me a bad situation so I know how to.
So again, well, I will say, like, what you do, if you do start it and you do have a significant drop in your blood
Right.
pressure, you stop the drug, you wait until the blood pressure recovers, and then you restart it at
A
half the
small
dose.
half.
Okay,
So if you were at 50, which you're going to as an adult, you would take it at,
25.
yes,
Can you do it in 5s?
you can. And then you restart it and you start the whole process over again.
okay,
Because, and then that is your top,
right,
right?
right.
It's helpful, whatever happens to that, because we just had a situation in ICU where they started out at 50, we came in, night started at 50, we're at 30, and we came in, now we're at 30. Why? I don't know. There was no blood gas drawn, there was no weaning, there was no notes anywhere to say, why are we at 30? So whatever you do, make sure that you're putting and documenting, like, oh, I had it, we're weaning now, or I had to take it to 30 because per doctor, who would know, whatever that is. Because then the physicians coming in the morning are going, why is this at 30? It was at 50
And
when
then
I
you
left
just look
last
like a
night.
dummy.
And I'm like, I don't know.
Right.
So again, whatever we're doing, let's chart that. Progress note is wonderful.
Especially with stuff like this, because this stuff's like
Yes.
All I can see is a lawyer just sitting
acute.
through,
This
like,
is like
yeah,
high
this is
acuity
It is.
type
Yeah.
of thing.
It
So,
is.
Yeah.
It is. All right. So, we talked about CPR. Any questions? Because I know we went way over 20 minutes.
Oh, is this supposed to be 20 minutes?
Yes.
It's been 45, John.
I know.
do you guys put two-sided pumps on yours? Cause that's what I'm,
Two-sided pumps.
like this, but
Oh,
not two sides.
So
that way
channels.
you can
So
switch
actually you can have
channels.
4 channels per
That way you
neuron.
can switch it out easier.
So, switch what out?
When you're putting up a new line, that's how we used to.
Oh, well, there's, because again, you could take, when this is running, because you've got you could take this out and let it
'Cause there's
run.
still an- okay.
Yeah, you can let that run for probably, I don't know, an hour before you would run this dry.
You just squeeze it into the little tube and then.
Okay.
Yep.
I like it.
An hour, you think, huh?
So real quick, I want to go over some points on bronchoscopy here. Again, this is kind of more for nights, but
I don't know.
So-
I don't do broncs like this very often at all. So.
I know,
You don't?
I
No.
definitely don't.
well, I will say, again, the same thing, is the biggest problem is getting this up there, getting it plugged in, and getting your supplies. There are 4 supplies that we have that you can't get anywhere else but respiratory, right? The biggest is
Yes.
your adapter, right? There's a big
Yeah.
bag of them right here. So, again, it comes with 2 plastic adapters, right? One is larger than the other, right?
Yeah. as long
One's a
as
smaller
you
one,
have
one's a
your
larger
boxes
hole.
of
You
CO2
can put the larger hole on there, it's a little easier to feed your scope, right? So this is going on your,
Yeah, 'cause,
again, this is going
because
on
I'm
your
in
tube,
Florida,
just like
it's on
this.
4 liters, but it's
So,
really on 3.
This will be plugged, so when your physician's ready to go in, you simply
Is he
open
all right
it up, and the scope goes right in, and you can still be connected to your ventilator.
Oh, okay.
Yes, so this is key. Okay, this is key
Oh, what was it?
number 1. Key number 2 is a slip tip syringe.
Oh, so
Right.
probably we have is already
Again,
enough.
slip tip syringes, right here.
And you have these cardboard.
Well,
Essentially, to go to these.
So he
Yes.
needs his
Okay.
machine and
Well,
all of ours, because we
we
don't
We
have.
have
all of
We-
ours.
disposables too.
we have a disposable bronch too, but this is the main cart that's on in between the CCU and MSICU in the hallway closet.
Oh, really?
That's where it stays. Slip tip syringes cannot be obtained in the ICUs, right? So it's only us. So this is what you need to
Just
put.
Dip your juice
So
down.
where'd you get that syringe from? I'm sorry, I was on the call.
At the top drawer over there.
Yeah, this is where you put your.
Keep them in the
push your
car, but we
syringe.
also have them downstairs.
I think I'm gonna have a third.
Yes.
cookie.
What now?
We do have them in the department,
Okay.
right?
And then try and keep them on the car. So if you
no,
use
this
something off there,
this
you
is number
replace it.
2. Number 3 is.
Is that filled with something?
Nope, we're not yet. But what I would do is I have a little bottle of saline,
Okay, so.
and then I pull up about 10 cc's, and I have it available, right? Just feel like I put
Are you
the
supposed
slush
to
in
do
there.
that with lidocaine too?
I never use lidocaine.
Oh, I
I've
thought
never.
they shot lidocaine
Sometimes
down
they
there.
ask.
Sometimes they ask, and they'll ask, "Do you have any lidocaine?" I'm like, "No." And they're like, "Okay."
Mhm.
Because again, I don't have lidocaine. I have to go down to rehab and get. That's all the way downstairs. I'm on the 3rd floor. I
Oh,
don't
they
have
don't
a.
keep it on the cart?
No.
Oh,
No, we don't keep any meds on the car.
Correct.
We're not allowed to.
okay.
So again, this is not something that is a planned situation. Typically, it's like, okay, I need a bronch now. I need, like, we're plugged, or I need at least in the next 10 minutes. It's not something that, okay, we're gonna plan. We're not doing weighing needles. We're not doing biopsies. We're not doing cryo. We're not doing any of that. This is to go down to look to see what's going on.
Or just
Right.
like have a book.
Yes. So, part number 1, part number 2, part number 3 is the enzymatic pre-cleaning, right? And then part number 4 that you may not need, but if you don't have a bite block, all right, this is specific to us. These are specific to us. Everything else that you may need, you can acquire in an ICU.
That's if they're not intubated yet.
Or if they are intubated, but
Then
they
you
don't
have
have
a
a bite block, right? And typically, it's not gonna be a problem because they're probably gonna be sedated anyways, but again, you bite on that tube with a scope down it,
Oh,
you're gonna
it's
damage
not-
it.
I've
That's
seen people
not
bite
to-
even though they're sedated, so they don't, yeah.
So you
We
should
put
always,
bite block, yeah.
but most of our ET tube holders have bite
a
blocks
block.
now anyways. And I love it when you see it, it's like, oh gosh, you got a bite block.
Yeah, I think gosh.
So again, you can get gloves, you can get KY jelly, you can get Lucans, you can get 4x4s, you can get almost everything that you're going to need
In the ice.
in the ICU.
I'm
So-
finishing your sentences.
So the reason that I say that is because we had a big issue night shift. Again, I hate to keep saying that, but we had a big issue with them trying to find this, and it was a big to-do, and it was trauma, and they were wanting to get the bronch going, and it's like, where is this? And it was there all along. So a lot of,
So it's in
again,
the first
a
drawer?
lot of what we're doing is just getting the cart, getting the stuff ready. And all I gotta do is get it ready and operational and hand it to the physician, right?
Yeah.
That's all I need to
What's the name
do.
of that thing right there in your hand?
Vent adapter,
Vent.
vent elbow adapter.
Vent adapters next to the
Right.
And that brings me to the next question here, or next thing is, again, it's a lot of equipment. You plug it in, one plug into the wall,
Okay.
one button, right?
Okay.
One button turns it on, and you're good to go.
So you don't have to white balance.
Well, we're getting there.
Oh, sorry.
Oh, that's me, I'm supposed to be
You're
like.
going
they
too
said
quick.
plug
He
it
said
in,
one
turn it on.
button.
That
Always
just turns
make-
everything on.
Yes, always make sure that you have adequate PPE for everyone, especially face shields or at least goggles. And again, only one button is utilized to turn the entire system on. Right there it is. Connections, so
Plug it in.
right there, plug it in, plug it in. So we have connections here. You can have, you see it's got 1, 2.
One and
Look in there, 1, 2, right? So it goes in like this.
Bam.
And then you have to think, okay, well this is open, what's here? Because a lot of times, again, you have to think, it's been a while since I've done this. I'm not sure how this is supposed to work. So you got to kind of think through this and go, there's something that should be here. Okay, well what's this? Oh well, that, there you go. Line up your dots. Boom, right?
Yay.
So again, you're almost halfway home, right? We got our connections.
Thank goodness.
Now we're going to do white balance. So we have a little cup here, right, that allows you to white balance your scope.
What's
that-
that?
So it's just for coloring purposes. What you want to do is tell the scope what white is,
Okay.
kind of.
So you put that up there and then you have to
So
push a
you're,
button? or
yes, so you're going to put that into this little chamber that's white. Well, actually, first I think I got to push ignition.
Yep.
Push ignition, and that's the thing that screwed people up too. That's what's going to get your light activated, right? That's what's going to start the whole thing.
Now hit light.
So ignition is the big button,
Start.
the big,
Ignite.
it is, and that has bitten us before as well, right? You got to have ignition, because again, the physician doesn't know. All they know is, I just want a scope.
Yeah.
It works, right?
And
So,
if you don't know, they get
If you,
mad.
yes, and so again, ignition and then white balance. So we're going to do this, and then my white balance. You're going to hear a little ding. Maybe.
You have to hold it down, maybe.
There
There
you go. Right. So now we've got white balance, and then you're like, okay, here you go. Right.
Your job is now over, except you have to
So-
slide some stuff down.
So and again, what I do is I try to have
Is it
it,
jelly?
and there you go. See, it's.
Yeah, we put jelly on.
So what I do is I have everything ready for them. So I have gloves ready for them. I have PPE ready for them, and they walk in. They're like, "Oh, thank you." You know, they just really
That
appreciate
started out
it.
nice.
Yeah.
Mask and
It's
shield.
with ice that are through the whole thing.
So I will put like one of these, and I'll put a towel on the patient's chest, and I'll load a few things here. One is which I'll have like a bunch of these open, because what they like to do is grab it. I'll put a big blob of lubricant there, and I'll hold it, or it's right there. They'll take the scope and drag it through it, and then they'll take a clean one, and they'll grab the clean one with this, so their hands aren't sliding up and down that scope while they're introducing it into the ET tube, right? So I just have a bunch of these available for them. They're nice to have, around, right? So I have a bunch of 4x4s. I have some sterile saline that's
Already
ready drawn up and ready to go. You just kind of have, a lot of what we're doing is we're anticipating the next thing I need, right? And I think that's a lot of what we do, is if you anticipate, it's going to
Go smooth.
go much more smoothly. Again, the RT must have the capability to anticipate each step during bronchoscopy, including good assessment skills to detect changes in the patient's condition during the procedure. So what are you going to do to the vent? Yes, but what else?
Turn them up.
What'd you
Yes.
say?
Turn
There
them
you
up
go.
to 100%.
Turn them up and turn them down, or turn them off.
Turn
So
them off.
Turn off the
100%,
alarm?
100% FiO2, silence.
Okay.
All right, because the minute I introduce this into the airway,
Right.
I'm going to be, it's going to be crazy town on the vent, right? So that's why I kind of like to be on that side of the vent,
Or you can turn the alarms off, like you can.
or have somebody over there that can do that for you.
That's what I did once.
Because
I
what
was
I'm
so
going to be
wrong,
doing
and so, go ahead.
Between the physician and this card is I'm going to be holding the tube for him, right? Steady. So when they go in, and I'm going to be shooting in the saline when they call for it, right?
do you get this saline from?
Again, from the ICU or in here as well, but the little bottles of saline in the Kmart room of any of the ICUs.
Okay.
Yep.
Okay.
They're like, I don't know how many
You got a
mLs
green
they are.
lid and they got like 20 cc's?
You can get them in, I think, 50 and 100, I think is
Yeah,
what we have
50s
upstairs.
and 100s.
50s and 100s. But I usually get
I
the 50s.
think mostly 100. Well, we use hundreds, but
I just get whatever I see first.
yeah.
And
Right.
you get that gauze thing in those rooms too.
So, yep, all that stuff is in the ICU, I call them Kmart rooms, but,
They're clean rooms
They're
with
clean rooms,
clean
yes.
equipment.
Clean supplies.
yeah.
Clean
Supplies.
supplies.
Yeah.
And
Or
so
supplies.
that's a lot of it, is getting this machine up and running and assisting in the bronch as needed, right? And they're really pretty cool about walking you through, especially if you're like, hey, you know what, I haven't done this for a while. Okay, that's cool, we'll walk you through. As if you can set this up and get them the proper equipment, they're not going to be like, oh, I mean, every now and then you get
Or a little
a
crabby.
but typically they've been pretty cool with like working with you and walking you through. I'll need this, so you have that. Okay, good. You know, they'll walk you through that. So I'm always coming to it honestly. If you ever in a situation with a physician and you're like, you know what, it's been a while since I've done this, so if you can like walk me
Just
through, that'd be
remind
great.
me.
And they're cool with that. I mean, they're not there to like make your life.
you a hard
Yeah, they're really not. And if, my thing is if I'm coming to it honestly and they're still having a problem with it, well then I can't help that. You
Yeah,
know what? It is what it is.
You do what you
You
can.
do what you can,
and you do
and-
the best you can.
And absolutely. So when you are done, I will say, when you're done with this, I will have them, or once they hand it back to me, I will, while the suction is still connected, I will suck up the rest of that saline, right, to kind of rinse that tubing out. You get then, while you're still having your PPE on, you want to get your dirty box that you're going to have available, right? And what I do is I just set it there like that. I take this guy here, open him up,
This is fun. This
Open-
one looks fun.
open him up, right? And then you'll see the sponge is like a round sponge with like a split in it, right? So you rip that open, and I then take the sponge out, kind of wring it out a little bit, and then take it and then wipe it down, right? And then take the scope again while it's still connected to suction and suck it out the rest of that water that's in there,
Okay.
right? So what that is a pre-clean. It kind of takes the proteins away from drying on the inside of that scope. So then that gets the whole thing, the whole scope gets put down in here and it goes to the dirty room.
It's
It
sterilized.
gets sterilized.
So that's probably
properly.
saved a lot of scopes getting that protein out, right?
Yes, yes. Well, we used to just rinse,
Right.
but found that this was actually best practice, that you're actually using a pre-clean. So it's just one more step in safety.
Okay.
Right, it's all about safety for the next patient. Safety, safety, safety. Charting is going to look like this if I get out of the way. Charting is going to get, again, I don't get too involved with this kind of stuff here as far as the weighing needles and brushings and BA and stents and balloon dilations and stuff. What I'm more interested in is whether you were a lead or assist and any standby times available.
I thought we didn't charge standby time.
Well, again, this is a billable procedure.
Oh, okay.
So this is like bread and butter time,
Okay, gotcha.
right?
So this is where we make our money.
And then, I don't think there's anything, sometimes I have to answer yes to a BAL if he does a wedge. And so instead of, you know how we would do a mini BAL, well, they'll do the same thing except with a bronch. And they'll put a Lucan strap in between your suction port,
And suction
and
it
then
out.
that's going to the wall, and then they collect your BAL in that, right? So it all depends on what we're doing. Typically, sometimes you'll see them do that, but not always. And I guess that's probably it that I've ever used there. Again, this is a lot for, we're using the same kind of charting as rehab does, as far as Epic is concerned. Help your folks out. If you use this, you gotta put it back at least put a clean, go down and get a clean scope.
Where do you put
After you get the dirty scope, you put it in the dirty utility room. The first floor, you know where the first floor storage room is, where I just saw you today?
Yeah.
You know, back, if you go back that hallway, there's a row of cabinets.
Okay.
You'll see a cabinet with glass front. It's got all the scopes in there.
Oh, okay.
So at least put a new scope on, right? I mean, there's not a lot to restock because we've got a lot of everything. But what I do is I wipe it down. When I take the new scope, you put a new scope back. Because this is the issue, is the next person that goes gets it, well, there's no scope.
Okay.
And that can be problematic, right?
You said on the first floor where our equipment is, or down in the?
First floor.
First floor.
Yep. So the disposable is the same kind of concept, just much less,
That's a burnt procedure too.
yes, this is that disposable rock.
Yeah, this one is the one I use more actually than this one.
And if you look at, yeah, so this is the one that you're probably going to find that some people call for. Well, trauma likes it more than, I would say, the attendings, the other attendings, some of the other groups. And I'm like, so what I do is that when I say I want a bronch in room, my first question is, what equipment do you want? Do you want this or do you want this? I don't care. Okay, I'm going to go this.
Yeah.
It's going to be
Way
way easier, right? But I will say the picture is typically better on this, and as such, it's just what depends on what we're doing. A lot of people say the suctioning isn't as aggressive on this as on that, but again, I'm here to facilitate what they need, and as such, if they don't care, well, then I'm going with this. Some will say specifically this, right? So this is all disposable. This is the actual bronchoscopy scope itself, all right? It is a disposable
When did we get this? I've never seen
situation.
this before.
We've had it for a while. This is kind of broken. It's not coming back the other way. But, so it comes in 3 sizes. We have a small, medium, large. The 5.8 is the large. It's the largest lumen, followed by the medium 5, and followed by the small 3. So if I have an 8 or above ET tube, I will go for the large scope. Okay. Because why not? Go big or go home, right?
Bigger picture, right?
Correct.
Better picture.
Bigger picture, better, less obstruction, right? And so you have a power button over here. I am plugged in, aren't I?
Of course.
It didn't come out the wall over there. The outlet by the wall.
Nope.
Oh, there, maybe that's it. Wait. Uh-oh. Yeah.
Johnny, I have to go. I've been down
Okay,
there over
yeah.
the door.
Oh,
Sorry.
I got key safes that right here.
there we go.
You got it.
Thank you.
You bet.
Boy, you got a lot of food left, buddy.
I know, it's way better.
Eat some more cookies, Debbie.
No, I had one. That was good.
One.
So it's got blue to blue,
Green to green.
and green to green, and there you go. That's all there is to it. There is no balancing, there's no other,
I don't
there
know,
you go.
can we just, do I send you this adapter and everything?
Yeah, so the idea is for your patient, it's going to be the same. It's going to be the same setup, you're going to have the same adapter,
Okay.
right? You're going to have
You're
the
still
same
gonna need your
situation.
jelly and your,
Yep, you're still going to need your 4x4s and your lubrication and maybe a Lukens and your saline. That's all going to stay the same. It's just the equipment is a little different.
and it's less heavy. That's my main thing. This thing is like
Yes. It's a
crazy
bear.
big. It's a bear.
It's a bear to bring this in and around and get it
And this is more like a
where you need
fox.
And this is smaller than what rehab brings up.
But I just worry about finding the equipment.
Again,
for this
so
one.
what I do is unfortunately in the MSICU, Carol, the manager, does not want any extraneous pieces of information. pieces of equipment in this basket. So that's what contributed to the issue a few weeks ago as to why they couldn't find the VIN adapter. But just know that right next door is this with all of that.
Also, there's mini valves that have saline. Can we just take the stuff out of there if we ask?
If you
It's-
remember to put it back.
Yeah.
Because that's just the, yes, I mean, if
If
for
you're
no other,
working quickly,
yes.
you can literally just grab a mini valve kit and take out the saline and the blue thing, the blue
Yep.
adapter.
Yep.
But then you always want to replace it, like you said, because that's kind of mean to just take that out.
Right, and then you're screwing somebody else.
Yeah.
down
And
the
then
road.
right next to that, I guess it's true, the closet has all this anyways.
Yes, and so they didn't realize that, even MSI folks were like, what? And so I showed them, because they were like, well, what are you gonna do about this? This is the problem. I opened the door and they're like, wow, I didn't know this was in here. So again, it's around, it's just knowing, again, where to get the products. And I will say this, there's a big difference. Oh, I have to do a bronc, I just don't know, I can't do it, I've never been, I just don't know what I'm doing. There's a difference between that and going, well, Brandon, can you come up and, it's been a while since I've done one of these, I think I've got everything, the cart's in the room, I got it plugged in, I think I got all the supplies, can you come up and just check this before we start? That's a big difference, right? And I think we've lost that mindset. We need to we can't
Get
just,
assistance.
we need to let go, because I have been in that situation before where somebody throws their hands up and go, I just can't do it, I've never been shown, or it's been too long. And I'm thinking, well, do you have the cart? No. Well, do you know where the cart's stored? Yeah. Okay, well, I think you know how to
That's
push
half
the
the
cart from there to the room, and it's got a plug in it, and you know how to plug something in, right? Yeah, okay, well, you got that much, right? I'm telling you, but that's
half the battle.
a lot.
Yeah,
I'm not
yeah.
saying, so what I'm saying is there's a lot that we don't know. Cool, got it. But you know what? There's a lot that we do know.
And if you think about it,
And
you
if you
could probably
think about
even figure the rest of it out.
You can probably, at least before you need that assistance, I'm not saying you don't go rogue and do stuff on your own if you're uncomfortable with it. I'm not saying that. What I'm saying is take some initiative to kind of work through the situation. That's a lot of it, right?
Yeah.
And then say, hey, or during that process, hey, I'm on my way up here, can you meet me up here to help me with this? That's different than going, nope, can't do it, don't want to do it, don't know anything about it.
Yeah, the first time I had to do this by myself, I had to get Katie, because I was like, Katie, this is my first time, please help.
And that is why
But
we're here.
I did get it.
That's why we're here. That's
Yeah.
why we're a team, that's why
Yeah.
we work together, right? Just stuff like that, so. And on that note, thank you all.
Thank you, John.
Thanks, John.
Woo!
Very nice.
Love it. And I just threw two
Ice on the
ice.
floor.
It's only two.